Good afternoon, all of you. Concentrate post-lunch. The blood flow gets diverted to your GIT, etc. And therefore, you are allowed to sleep, but at least pretend that you are awake. But to make things worse for you, the lights will not be completely out. So, anyway, we now move on to the lower extremity, and I am going to talk on the intracapsular neck femur. All of us know this from theory, that the cambium layer is absent, so only endosteal callus forms. Synovial fluid from the joint enters, clotting. Why is it called as an unsolved fracture? Primarily because there is no consensus amongst us as to what will give you a predictable result. So if it's a grade 2 or a grade 3 neck femur, and if I do this, at the end of this much time, this will be the result, is something which is not predictable. And then there is a sword of avascular necrosis. So in spite of doing everything perfectly and having a very good result by the end of 1 year, at the end of another one, you could still land up with something really troublesome. Obviously, all of you know the reasons why you have a high rate of delayed and non-union. Primarily, it has to do with the blood supply, inherently poor blood supply consisting from the medial and lateral circumflex vessels. If you look at this picture, this is what happens when there is a neck femur. Now look at this anastomosis. It's subsynovial circle of Chung, and after the break here, this is what remains. So it's really a poor vascularity in the head, and therefore there is no way you can predict this, whether this is really going to happen after the fracture, and therefore you cannot predict whether it will go into an avascular necrosis or not. Typical bimodal distribution, quite easily understood. Incidence doubles with each decade beyond the age of 50, and primarily it is because of neurogenic problems, osteoporosis, vision problems, etc. In the young patients, it's always high energy trauma. So what challenges do we face today in terms of the intracapsular neck femur? The first and the foremost is how to grade the severity. The available classifications do not tell you about the severity adequately or even the outcome. Can you predict union? Not really. Can you predict avian? Not at all. Whether you do a closed reduction or an open reduction, what would be the best modality of fixation to give you a predictable result? Which arthroplasty do you select in old patients? So all these are unanswered questions, and I hope to make things simpler in the next 5 minutes. So please stay awake. Classification, the standard Gardens classification, high inter-observer variation. Again, difficult to predict complication and union rate. All it tells you is that type 1 and type 2 are undisplaced or minimally displaced, and type 3 and type 4 are grossly displaced. Powell's, more theoretical but completely irrelevant as far as clinical outcomes are concerned, because there is no correlation with the angle and the subsequent incidence of complications. So the AO classification now, and we are looking at this. So it's 3-1B as per the AO classification, 3-1A being extra capsular and 3-1C being the head fractures. So B1 is a subcapital fracture with very minimal displacement, a valgus impacted kind of a fracture, usually seen in this age group. B2, a transcervical, different fracture angle and line, and seen in this variety of patients. Usually these are the young patients. And B3 usually is a subcapital, no impaction, and a displaced fracture. So what determines the outcome? either whether it is displaced or undisplaced, thereby meaning whether it is stable or unstable. Investigations, you customarily take pelvis with both hips AP view and a cross-stable lateral view. There will be at times a valgus impacted fracture or a patient walking into your clinic with very minimal pain or internal rotation only. The patient is walking, he is able to do an active leg raising, and the X-ray seems normal. So this is where you need to do a CT scan which will show you this intracapsular fracture neck fever. It's a very typical 65-year-old postmenopausal lady who gives history of something happening in the hip while trying to get up from the bed and mild pain in the hip thereafter. But she's able to walk, she's able to do active leg raising, and a CT demonstrates the fracture. So that's the role of the CT. MRI should be indicated in old fractures to assess the vascularity of the head. Bone scan not really indicated in a traumatic situation. Factors to consider with the age of the patient, whether he is young or old. Arbitrarily we choose 65 as the cutoff line. And the fracture characteristics, whether it is stable or unstable. What treatment options do we have? Beginning with non-operative, we have all these operative options, and in a minute I'm going to explain when you should do what. So non-operative treatment, the only indication is perhaps a totally undisplaced valgus impacted fracture, and that too in a patient who is not fit for surgery. For all other fractures, I would strongly advocate operative line of management in an intracapsular fracture neck fever. How do you treat non-operatively? 3 weeks of bed rest in abduction. Traction is not indicated. Attempt ambulation or partial weight bearing at the end of 3 weeks. But it has its complications. Almost 50% get displaced or more than that. And all of you know the complications of recumbency, right from mortality to pneumonias and bed sores and urinary tract infections and so on. And therefore, non-operative treatment should be reserved only for patients who are not fit for anesthesia. Undisplaced fractures, safe and simple to fix. You could do it percutaneous or mini open also. So you get something like this, a valgus impacted fracture, fix it percutaneously without attempting to reduce. So do not try to reduce, because then you are disimpacting it, making it more unstable, and what was type 1 would become type 2 or type 3. So don't reduce, fix it in situ. And what do you fix it with? 3 cannulated cancellous screws are enough in a valgus impacted fracture. Enough to mobilize the patient non-bed bearing. All displaced fractures, the goal should be anatomic reduction and stable fixation, irrespective of the displacement and irrespective of the time since injury. So whatever you do, try and possibly save the head. Operative treatment, paper published by Hajdukevich in 2004 JBJS, 73% healed without AVN, and this is about 15 to 50 years of age group. So 85% overall good results, primarily influenced by 2 factors only, and that is initial displacement and the quality of reduction. Elderly patients, internal fixation is not the treatment of choice. Joint arthroplasty gives a much more reliable results, as I would show you in further literature. Whereas in young patients, internal fixation is the procedure of choice, arthroplasty is less reliable. So then, what is the standard algorithm of treatment? In a displaced fracture, in a patient below the age of 60 years, you do internal fixation. 60 to 75 years, you think of a total hip replacement, or at least a bipolar hip replacement. And beyond 75 years, think of unipolar hemiarthroplasty. Now, 2-3 important aspects as far as surgery is concerned. Timing. Swiatkowski in 1984 and later on Jain in JBJS A 2002 presented this paper saying that every intracapsular fracture neck femur is a surgical emergency and it must be fixed in less than 8 hours. Otherwise, the avian chances are more than 20%. But this was level 3 and level 4 evidence. If you look at the recent evidence, Mohit Bhandari published his meta-analysis of 18 studies involving 547 patients in OCNA 2010. And then later on supported by many others, level 1 evidence, which says that there is no association with the timing of surgery and avascular necrosis. There is no association with timing of surgery and the rate of union. So there is no difference in patients treated before 8 hours and after 48 hours. Capsular decompression, another controversial topic. What does the evidence say? There is no significant benefit of capsulotomy on avian, and this is a prospective randomized controlled trial